One of the sad things about our industry is we can't increase our prices.
The national average of patient AR per visit is $37.86. HealthActions is 58 cents.
We not only train the front office, but we also train all our professional staff as well.
Jean, maybe you could give the audience here an idea of how we've collaborated around changing process in the context of patient responsibility.
Absolutely. And we had this discussion, and you sent me.
Meet Jean Weatherly, Director of Administration, and Debbie Powell, co-owner of HealthActions Physical Therapy. Together, they've implemented a system that is bucking national trends and has increased their revenue per visit.
We've increased our revenue per visit.
It really has had a huge impact for us.
You guys are amazing, and you've changed a reality. The one caveat here is that this is the Rehabbing Your Revenue Cycle podcast, and I'm really happy to have a couple of guests on today, Debbie Powell and Jean Weatherly. They're from HealthActions Physical Therapy in the South, and you'll tell by their accents as soon as they start to talk. And conversation today is around the concept of patient financial responsibility in, the physical therapy practice. And as years go by, patients' responsibility is on the increase. I can tell you that, we have national data on PT practices across about 30 states for several years now. And the average amount of money coming out of a patient pocket in 2023 was 16.1% of the total practice revenue. In 2025, it's 20.22%. So it's gone up about 25% from 16 to 20, percent. And that trend's probably likely to continue. There is a couple of things that determine ultimately whether or not for an individual practice that would be true is what percentage of your patients have secondary insurance and how much of the patient responsibility is picked up by a secondary. So, but all that said, we're going to talk about what a successful patient responsibility outcome looks like. I'm going to just start right off with data. I brag about this practice, these ladies. Debbie's an owner. She's one of the owners, one of the founders. Jean is the head director of administration. So, and how long have we spent together? We've worked together now for 4 years, 5 years.
Yes.
I'm old enough to forget, how long it is. But anyway, and just so everyone knows, we do not do this practice as billing, but I've worked with them really as a former practice owner, consultant, trying to help another practice basically become a better business. And so maybe we'll just start with a quick, very, very, very quick, input or orientation to what your experience with just the opportunities that we talk about and discuss around how to improve your practice as a business. 5 years ago, what was your mindset and where are you at today in terms of things that you've actually done and implemented, taken action on that have taken you from a different reality then to a much different one today? So I believe there's a lot of perception in the industry that, first of all, it is a very hard time to be in this business, but I also tell people all the time and believe that there are many, many opportunities to improve systems, controls, process, data, information, to still have a better practice today. And tell me how your experience has been in the last 4 or 5 years in that regard.
Bob, thank you very much for having us here today, and thank you for working with us over the last 4 to 5 years, because you have been very, very helpful, very instrumental. Our billing department, and I would also give kudos to Jean here, because she is an excellent person doing what she does and overseeing the people that she does. So with Bob's help, we've really implemented a lot of policies and procedures in our billing department, in our patient registration, front office collections with our patients, with our accounts receivable review. And so we have gone into great depth with our revenue cycle from start to finish. And Bob is excellent with coaching us on um, all of those regards, every component of that, and has helped us to look objectively at each section of these actions so that, again, we can improve our collections. I think, one of the sad things about our industry is we can't increase our prices. We can set the fees higher in the system so that hopefully if they ever get around to giving us a raise, we can take advantage of that. But at the end of the day, we don't get a raise. And so we have to do better with what we get, and we have to get more of what we can get, and we have to understand all the strategies to maximize that reimbursement. And so he's helped us to look at every one of those avenues and improve that. And, so I would say that we've increased our revenue per visit. We've looked at the better or more appropriate procedures or codes to use for billing, and we've maximized the coding for the purpose of the treatment that we provide, so that again we're doing the best that we can for the patient, and then we're doing the best that we can for ourselves to capture the revenue that is there as an opportunity. So and then as we've tried to we've educated our providers on some of this information or a lot of this information because we want everyone to understand the value of what we provide. And so if we can provide value, which is what we coach our teams to do, all of our provider teams, then the patient is more um, responsive to pay their part. And so then it's a cycle. And Jean, as I said, does an excellent job training all the administrative staff on what they need to do their best at collecting money on the front side. So that was a little bit of a ramble there, but maybe that gave us some idea of the things we've looked at and worked on over the last few years.
I think the most important message for PTs in private practice today, right? And I no longer own a practice, but my son does, right? He's a DPT, and my daughter-in-law is a DPT, and they own a practice. So my purpose is to try to help business owners, practice owners to just have a better business, right? It's not, and there's many moving parts to that, and Debbie and Jean and their business, right, has grown. It's grown at a decent clip. They're up about 1,000 visits a month compared to where they were 4 or 5 years ago. But the big thing is that revenue per visit is also in the $5 to $6 per visit range in the same period of time. And if you think about what's happened in the payer world around payment, right? No one's paying more today. I mean, there are exceptions to that. There are some states where Medicaid's gone up and some other things, but unless you've negotiated different rates or whatever, the general. I saw some data around Medicare from APTA recently that said in the last 10 years, Medicare revenue is down 40%. So to increase scale and to increase the value of a visit is going against the trend. And what's important to know is that if you run your business like a revenue cycle business, and if you are a physical therapy, really any kind of healthcare private practice that's dependent on third-party reimbursement for your revenue, you are a revenue cycle company. And revenue cycles, like people's bodies, there's lots of opportunity to rehab those, to make those better, right? And that's what this is about, is how you look at all of the different integrated moving parts of your business and say, how can we optimize? Where are there opportunities to improve so that we can have a better outcome than not doing these things, right? And you're just living proof that you can, and it takes a lot of work, right? This is not easy. But having a structure, having a plan, having data, just having the right kind of focus, strategy, focus areas. If you work the problem, you can really improve your business. And so, revenue cycle, I'll just contextually position this a little bit, and then we'll let Gene have a word here. You know, the revenue cycle business is about three things. Number one, converting provider time into potential revenue. That's where it starts. You want to maximize that conversion of time to potential revenue. Everything that you do functionally within your practice, all of your different systems, processes, functions that exist, your credentialing, your patient registration, your authorization management, your verification of benefits process, the actual clinical documentation, your coding, your use of modifiers, the patient responsibility piece, the billing process itself, how you market and how marketing drives payer mix, how you negotiate contracts for your in-network payers that you work with. All these things are revenue cycle functions. And revenue cycle as a whole, when you think about all the stuff you do in your practice, well, that pretty much covers it. Not a lot going on other than HR and employment stuff, which is still related. Is not a revenue cycle function, right? But so providers convert time to potential revenue. Revenue cycle management in totality converts potential revenue to cash. And one of the big pieces of that, we just said that the average patient payment as a percentage of total revenue is up to 20% of the total. It's up 25% over the past just 2 years, since 2023. And so collecting money from your patients is a big piece. The average physical therapy practice has a profit margin around 10%. And if 20% of your revenue is coming from your patient, and that's a significant piece of revenue cycle that has to really be designed, structurally managed, executed on, and make sure that it's optimized. It's a big thing. Not only is it from a revenue perspective, but from a time perspective, right? When patients owe you more money, there's more statements, there's more phone calls, there's more explaining, there's a lot of things that come and from the cost side. And so as an industry, we're under downward pressure in terms of payment levels, and we're on upward pressure in terms of costs. You have to pay people more today. Cost of livings are up. One element of cost, which most don't really think about, that we really have more data on than anybody, is how much complexity there is in the system. And to have great patient financial responsibility outcomes, you have to have the right systems, controls, process, data to not only maximize the financial outcome, but minimize the complexity cost. So we've talked over these years a lot about what that optimal process looks like. So Gene, maybe you could give the audience here a little bit of an idea of how we've collaborated around changing process, systems, controls in the context of patient responsibility.
Absolutely. And I also want to say thank you, Bob, for all of the guidance that you've given over the years. It really has had a huge impact for us. 3-4 years ago was we had this discussion, and you sent me the forms that you were using for financial agreements and for credit card authorizations, and all of those forms for the front. And so we still use those forms today. One of the things that I think is key is that as part of our training, we not only train the front office, but we also train all of our therapists, all our professional staff as well. Because one of the things that I've realized is that most people, unless they are in billing and insurance, don't really understand how to read an EOB or how the insurance applies the deductible and then does the write-off. And so that's part of our training, is part of our administrative training that we do with all our professional team, is that we show them, this is how the insurance actually processes, and how, like, if a person has a deductible, how that will look, and that they are not getting any money for that visit unless they actually do the time of service collection. So we try to make sure that they understand the importance of that patient out-of-pocket money and how that really impacts their cash per visit. And so, I think the entire staff knowing that has really helped a great deal. And then what we do, of course, we verify the insurance and we do the financial arrangement in easy to read and easy to understand terminology.
Let's hold those thoughts for just 1 minute, because I want to walk through. There's about 7 critical structural components to the process of collecting money. But at first, I want everyone to know how absolutely amazing you guys are at collecting the patient financial responsibility pieces from your patients. I'm going to give the audience here some data. So I'm going to start with, I'll take these by topic. There's about 5 or 6 different data points here. The national average on the amount of accounts receivables, that is what we do is we convert total patient AR to a per visit basis based on your current monthly run rate. The national average of patient AR per visit is $37.86. HealthActions is 58 cents, 1.5% of the average. The patient accounts receivables per visit on a current AR, 0 to 30 patient AR per visit, the national average is $4.15. That is up 37% over the past 2 years. It's $4.15. HealthActions is 58 cents. And you say, well, wait, you just said 58 cents. Well, it's because they don't have any patient AR over 30 days old. The national average of the amount of patient AR of the total that's over 30 days old is 89% of total AR. HealthActions is 0. The national average for patient AR over 120 days old, that's a percentage of the total patient AR, is 64%. HealthActions is 0. We look at patient AR percentage as a percentage of production. So we take your patient AR over your total gross charges. It's a really good way to think about, the it's a relative metric, and relative metrics are way more meaningful than just individual data points. So the national average of patient AR as a percentage of what you bill out every month is 12.74%. HealthActions is 0.23%. One more data point. We calculate the patient time of service collection shortfall per visit. Basically, how much more did you need to collect from each patient on each visit to not have any patient AR? And that's about $5. It's $4.94 per visit short. On average, HealthActions is 76 cents. So, here's a practice that does, do you mind me saying how many visits a month you guys do on average? You're in the 8,000 range, even maybe a little bit more. So just normalize yourself to that. Where are you at? Their total patient AR, as of July, was a little over $5,000. And it's all in the 0 to 30 bucket. 8,000 visit a month practice with $5,000 in patient AR. That is absolutely amazing. But you know what? It's doable. If Debbie and Gene and their team can do it, you can do it. The difference is, and I can tell you that we tell all of our client base the same exact thing. The difference is execution. It's being able to take a best practice type process and actually do it. Actually implement, actually monitor, actually change, actually influence the team to do the right things. And so you guys are amazing at it's easy for me to tell you, well, this is how I know it works. This is how it should be. But you've actually implemented, you've done it, you've executed, you've changed a reality. The one caveat here is that they have a little bit lower, the national average practice nationally has about 20% of their revenue coming out of the patient pocket. Their practice is at about 11. So what that means is that they have kind of a higher percentage of their patient mix that has secondary insurance to cover patient responsibility. So, but we're so far below. I mean, we're talking they're in the 1% of the national norms. The fact that they have 50% of the need to collect doesn't change the fact that they're just tremendously more successful at this. So the parts here, the systems, the controls, the processes, right? Patient registration, how you determine the amount of money that's owed at the time of service, then collecting that amount. How many different offices do you have? 11 offices. So at 11 front desks, you got to collect money, right? And they all do it. They all do it well. So you gotta know what to ask for by patient, and then collect that by patient, and then there are times where patients aren't going to pay. Oh, I forgot my wallet today, whatever. You got to have the plan B, right? The backup, credit card on file, ACH on file, whatever it is. You got to have a mechanism of collecting from your patients once you know they owe you money. Then you actually have to collect, right? You have to use that structure that you have in place, that you have agreement with, a patient registration. You have a written policy that they understand, that they sign. They know how it's going to work. And you just do these things. You don't forget to do it. You do collect. And then last but not least, I think, you've mentioned staff training, how you make sure that everyone's aware that it's actually important to collect money from patients. It's a norm throughout healthcare. When was the last time somebody went to a dentist without paying something right then and there, right? For some reason, I think some people in the physical therapy world think that doesn't apply to them, or they feel funny about collecting money for some reason. We're way underpaid, as PTs in private practice. So, that's, there's many moving parts. And last but not least is, I believe, that the success of collecting money from patients beyond the admin policy procedure, the clinical experience, the perceived value the patient has every time they're in the clinic with their provider, has tremendous power in terms of supporting the goal of collecting money from patients. So, what advice tidbits do you have about the patient registration process, understanding patient responsibility? What would you like to share on that?
Verify the insurance is key. And then we have two ladies that are kind of centralized, that if there is a question, they've got somebody to go to make sure that they get the appropriate answer.
How do you go about determining what you're going to ask for a patient at the time of service? You do collect at the time of service, correct?
We do.
How
So
do you know what to ask?
if the patient has a deductible, our set standard is $140 per visit until that deductible is met. If a patient has a copay, then what we do is typically because that's a percentage. So 20% for us is the same as $25. And so we ask for the deductible amount for each visit as well as the copay amount for each visit.
So how does the person at the front desk know that?
They are trained on that. And then that is also a part of our front desk manual. We have a manual for operations, and then we also have a manual that is just called simply Verifying and Handling Insurance, and it's broken down by each insurance type.
And you've already said something that's super important. What happens every January 1st?
Right. All that has to be updated.
Deductibles happen again, right?
Have to be
Even
reset.
in some cases, their insurance changes, and you got to re-verify. But you said something super key. When you know they have a high or a deductible that's unpaid, you're collecting a different amount from those patients at that time of service than in August. there's seasonality that matters to what your policy is, what your process is, and how much you ask for. What about the actual act of collecting money from the patient? So I owe you $25 today. How does that happen when I'm at your front desk? Do you do that when I arrive for my appointment, when I'm leaving? Do you come out and tackle me in the gym and take money out of my pocket? Or what do you do?
We do it at time of arrival. So when at check-in, one of the things that's part of our training is that everybody is a creature of habit, and that it only takes a couple of visits to train a patient that you will be seeking that copay whenever they check in. And, on the other hand, it only takes them a couple of visits to train, if you don't ask for it, that you're not going to be seeking that money as well. So, and then it's just, we try to do our training in such a way that it's just a norm, because it is. You said that just a few minutes ago. It's just normal. When you go to a medical facility, you have an out-of-pocket expense. So that's just normal, that we're going to take that money, and that's an expectation.
In your clinics, is every patient that you treat rich?
Not at all.
No, they're pretty normal Americans, average
Normal, yes.
income. So I hear a lot of stuff like, well, they just can't afford it. They push back on, well, $25 out of pocket every time I walk through the door. That's a lot of money. What do you say to that?
Their health is worth that. Don't they think their health is worth that? And then and that's one of the reasons why we train not just the front desk, but the entire staff on how insurance actually works, because they help in the back to give that value and to make sure that patient is getting the value for their money.
So let's just, since you brought that up, let's just talk about that for a second. So the experience with the therapist, the value from a health perspective, and how the patient perceives that, you believe that contributes to your success at collecting money?
100%, yes.
Anything you want to say on that, Debbie, as a therapist?
I tell all of our therapists we're only as good as our last visit. I heard that from Bob Kowalick. And I repeat it many meetings so that they can remember, because that's so true. And if we don't make a difference with every visit that we provide, what are we doing? That is our reason for being. And so we try to drive that message home over and over. And hopefully we've hired people, and we have people on our teams that they believe that, and they feel that, and they make that real. And so that is so important. And I do see that in the surveys from our people, and the net promoter scores are high, and I'm very proud of that. That they are doing a great job taking care of people.
The patient, because they have a prescription from a doctor, isn't committed to coming to see you for an entire plan of care right from the minute they walk through the door?
Absolutely not.
You have to create an experience every visit that causes them to go, all right, I'm coming back. And is there anything, I know we've talked about this, but just throwing it in there, is there anything you do that you have therapists do before the patient leaves to try to impact that arrival rate for the next visit?
We need to share with them what we're going to do at their next visit, and make sure that they know that we know where they are and what they need to have done to help them get
ask
better.
them to be there, right? You need to say, hey, I'm going to see you.
Oh, yes.
Right.
Oh, yes. They've got to be there in order for us to do this.
We had a similar scale practice, a little bit bigger than you guys. We had 95% kept appointment rate, because we made sure we talked about the importance of being here the next time. Awesome. Couple more things. So you've got people understanding their responsibility from the first day. They're expecting to pay. You know what to ask for. They're expecting to be asked for it. You ask them upon arrival at the visit. The people at the front desk are trained to not feel bad about that, and know that it's normal, and expect that payment. The patient is there. They're prepared to pay. Sometimes they don't, and you have a plan B in place. Do you have a credit card on file? What do you do if turns out that they're discharged from therapy and they still owe you money? Are you chasing them down, making phone calls? How do you pay yourself?
No, part of our financial arrangement is that from the very beginning, if they have a credit card, we ask to save that credit card on file. And the financial arrangement there is stated that after all insurance efforts are exhausted, they will be charged for any remaining balance.
You don't have Post-it notes all over the office with their credit card numbers on it, right?
We absolutely do not. No, sir.
So you store these in a compliant, secure type of thing. Are you using your the clearinghouse Waystar, using the EMR, using a third-party credit merchant processing? What do you use for that?
We're using the EMR.
Okay.
That's where it's all stored. And then just to make sure that they all understand that, there's on that little section in the financial arrangement, they initial it, and then they also sign at the bottom. And what we do is that if we run the credit card after discharge, the finance department will call them and say, I'm running your credit card for this remaining balance, and give them the balance so that there's no surprise.
We mentioned that you have a lot of secondary insurance. So that's a patient registration thing too, right? You got to make sure you get the primary and the secondary, and and you guys are great at not sending a patient a statement for a charge when it's actually secondary, because you did a proper VOB, but that they have more than one insurance, and you coordinate those benefits, and you're really good at that as well. So, and you mentioned training, so you have documented systems, controls, process, right? You have actual stuff. And I know that we've shared back and forth about kind of what those best practices look like, and you've implemented those things. Was that actually helpful?
It was extremely helpful.
Does it matter what's on the piece of paper?
Yes. I think that, just making sure that all the staff understand it and that all the staff follow it. And we do audit, and we do on our weekly stats, we pull time of service due, time of service collection, and we assign a collection rate. And so we look at that on a weekly basis with all of our front office team members.
Do you have any kind of incentives for that type things? So you tie that metric into compensation somehow?
Yes, they have certain measurable items that they're accountable for, that if they maintain those actions, then they are eligible to participate in the bonus system on a monthly basis. And they are often very eager to participate and do well. They want to do well. So it does help with getting them to do it right.
Well, I really appreciate you sharing your experience around this super important piece of revenue cycle. It's structured, you have process, you know that people execute, you track it, you monitor it, you incentivize them to do it. You communicate, your patients understand, you put all these pieces together, and you are just absolutely just blowing away national averages on your success rate. So, and like I brought up that one kind of silly point for a reason, that, not everyone coming to your clinics every day is independently wealthy, right? This money matters, right? It's not like it doesn't matter to your patients. It matters the same to your patient as it would to any, except that they understand it's their responsibility, and they also have a perceived value of their clinical experience with your locations and with your providers that say, yeah, this is worth it. And it takes the whole thing, right? It takes all these parts. Any one of these out of order can negatively affect the whole outcome, right? And we have data, right? The data matters, and making sure they have the right information about knowing, how this stuff is working. Well, I don't think there's any excuses right out there. If is there anything special about you guys? You got some kind of magic sauce or something that makes you just a whole different kind of human being than anyone else that owns a practice or runs a front office, that causes you to have success doing this, that prevents someone else?
Yes. I don't think so. I think it's just, you set your policy in place, you define your procedures, and then you do it consistently.
Yeah, you're normal practice owners, administrative directors with normal patients, normal team members, normal therapists that just do an abnormally well job of executing structure and doing what you need to do and making sure that the team wants to do what you want them to do, right? And that's super critical. So if you guys can do it, anybody can do it. One quick last comment before we go. We do have some clients that have pretty large negative patient balances. Right? You guys are really close to zero. And zero is ideal, right? You don't want, the flip side is you don't want to have to pay all your patients back because they've overpaid you, right? You don't want every patient, you have to have a credit balance because that takes a lot of time too. We haven't really talked much about, but I have all kinds of data on the time cost of needing to issue statements, needing to call patients, needing to collect after they've been discharged. The fact that 64% of all patient AR is over 120 days old means that if you don't do it successfully on the front end, you never do it. You don't ever get paid. Eventually that 64% is going to sit there. It inflates your AR. It causes people to have to resend statements, more phone calls. It's just such a huge time creator. It's a time inflator. And so optimizing this process, getting close to zero, not having to chase people down for money after discharge, not having to pay everybody back after discharge, is just a very efficient outcome as well as financial. And there's a definite relationship between the efficiency of any billing process and the financial outcome of any revenue cycle process. So I really appreciate you guys joining me today, sharing with whoever's listening about your success at having a great financial patient financial responsibility outcome that really is one moving part in an overall very successful practice that's bucking the national trends on revenue per visit and financial outcome for the practice as a whole. So you guys should feel awesome about that. Any parting comments you'd like to leave for anyone?
All the process. Thank you, Bob.
Gene?
Fine.
All right. Well, I appreciate you being here so much. Maybe we'll have you back some other day to talk about some other parts of this, like patient commitment to plan of care and things like that. So lots of moving parts here.
Thank you. Mm-hmm. Bye-bye.